Good afternoon, everyone, and welcome to the forum of the webinar. As we all know that the non-invasive ventilation in pediatrics is evolving day by the day, and the acceptance of importance of active humidification and high flow therapy by clinicians and paramedical staff and its benefits for patients is also increasing. So to restate more about heated humidification and importance of high flow nasal cannula therapy in terms of overview, use, and its application, it gives me immense pleasure and honor to introduce and welcome Dr. Sanjay Swami and Dr. Surendra HS as a speaker of the webinar, and the topic of the webinar is non-invasive ventilation in pediatrics. Dr. Sanjay is the leading consultant for Department of Pediatrics and the Chief Pediatric Intensivist at Sparsh Hospital, Bangalore. Following completion of his master's degree in pediatrics, he obtained fellowship in pediatric intensive care from Manipal Hospital, Bangalore. He pursued advanced pediatric intensive care training from prestigious Birmingham Children's Hospital, UK. He has been extensively trained in training sick neonates and children with complex conditions. Dr. Sanjay Swami is amongst very few pediatric intensivists in India who has worked at consultant grade in the UK. He is accredited instructor for Pediatric Advanced Life Support, MRCPCH training program, and for Human Factors Training, UK. His presentations at international conference, the clinical course of bronchiolitis, patient admitted to PICU, and the effect of winter surge on elective cardiac surgeries was published in the Intensive Care Medical Journal. We have the second panelist here, Dr. Surendra HS. He is currently practicing as a consultant pediatric intensivist and medical director at Natus Women and Child Hospital, Bangalore. Dr. Surendra has done fellowship in pediatric critical care at Achi Kamakuti Child Trust Hospital in Chennai. He is trained in caring for a variety of sick patients, conventional ventilators, high frequency oscillating ventilators, hemodialysis, central line, invasive BP monitoring, ICP and CBP monitoring. As per his interest in academics and clinical research, he has done a case report on the autoimmune encephalitis and Langerhans cell sarcoma. He has also published a clinical paper in procalcitonin in septic shock distribution anemia among Bangalore adolescents, association of vitamin D with severity of pediatric asthma. He has also completed NILS and PLS program. More intelligence, super smartness, perfect application of knowledge, and more dedication towards society. So more will be the dialogues for the personalities like the doctors. So without wasting the time, I would again like to welcome you both and request first to Dr. Sanjay to kindly take us through the very important and the interesting topic of every pediatrician. So thank you so much, and over to you, Dr. Sanjay.
Thanks so much, Dr. Ratnakar, for such a kind introduction. I need this permission to show the slides, to show my screen.
You can share your screen, sir. Just click on the share screen button.
Okay. Click on where, sorry?
Click on the share screen button in the
yeah. Yes, I have it. Yeah, is everybody able to see my PowerPoint slide?
Yes, sir, it's visible.
Yes,
Yes, it's visible.
Excellent, thank you. So, thanks, Dr. Ratnakar. So today's topic is a very interesting topic. It's about non-invasive ventilation in children. There have been so much of development in this field during the last decade or so. I mean, 15 years back, I think we hardly used any kind of NIV in children. NIV was restricted to adults and or even adolescent children. And today, the progress is such that right from the newborn period and the preterm period until the infants and children, people have become comfortable in using NIV in every indication. So today, let us learn something about what has happened in the last 10 years, what kind of NIVs are available, I'm going to predominantly talk about something that we can do in the ward setup rather than in the ICU setup. And then, of course, when there is an ICU setup needed, it will go to the next level. So initially, so this is where I work. I work in the Sparsh Hospital for Women and Children, which is on Infantry Road. And we have a 12-bedded PICU with all the facilities needed. I worked in the Birmingham Children's Hospital in 2011 and to 2014, wherein I was the a clinical fellow in pediatric ICU and in the transport service as well. I was part of a team in the retrieval service, wherein we used to have a consultant and a senior nurse always available round the clock for any child needed who needed transport. Quickly coming to today's topic, so there are two types of non-invasive ventilation, predominantly called the CPAP and the BiPAP. CPAP basically means continuous positive airway pressure. When we say continuous positive airway pressure, it means the positive pressure is delivered to a spontaneously breathing patient throughout the breathing, throughout the inspiration and during the expiration in a continuous way. So there is one constant level that is maintained throughout the inspiration and the expiration. And so this is especially useful for those who are suffering with oxygenation issues, those who need support for the breathing with oxygenation issues, whose oxygen requirement is increasing, the FiO2 requirement is increasing. Whereas, we'll come back to that exhaled gas part of it later in another slide. Whereas in the BiPAP, which is the other type of positive airway pressure, which is the bi-level positive airway pressure. Bi-level basically means that we are going to support both the inspiration as well as the expiration. As we all know, the expiration basically is important to get rid of the carbon dioxide. Our lungs are constantly trying to take in the oxygen and bring out the carbon dioxide. And so that's why it is especially useful for those who have type 2 respiratory failure or the high carbon dioxide type of respiratory failure. Of course, we have the interfaces for the BiPAP using the nasal and the facial interfaces, which we will talk about a bit later. So as we understand, the BiPAP basically means there is an inspiratory support and there is expiratory support, which we set it up as an IPAP and an EPAP separately on the machine. And it is, of course, useful in someone who has high CO2. Indications of NIV, I think the oxygenation issues happen predominantly in those with, pneumonias and ARDS and obstructive sleep apneas, the initial phase of obstructive sleep apnea, those with chronic respiratory insufficiencies, those, let's say there are visas who come in with respiratory distress, those may be the usual hypoxemic indications for usage of CPAP. Whereas for the BiPAP, those who have high carbon dioxide levels, chronically, let's say there is a child with neuromuscular disorder who's unable to breathe out all the carbon dioxide out. There are those with thoracic cage skeletal disorders, those with hypoventilation syndromes. These are all the chronic patients wherein the carbon dioxide is accumulating over a period of time. And there is a bit of respiratory acidosis. If you do a blood gas, you will definitely see a low pH, 7.2, 7.1, and there's a high CO2 of 60, 80, which may be a normal for that particular patient. When those patients come with a bit of altered sensorium, respiratory distress to the emergency, this may be something to consider with this situation rather than intubating such a patient. Intubating will make them, dependent on the ventilation. We are always scared to intubate a child with neuromuscular disorder or a chronic patient. So we would like to get away with putting a simple BiPAP and managing the patient. So coming to the complications, of course, when you're pushing a lot of air inside, you would expect that the patient would fight with it. I think that is the first natural reaction to this provocation of pushing air on the face of an infant you can imagine how tough it is for the infant to tolerate the blowing of air on the face. So that's the initial dysynchrony is what we always expect in a child whom we are trying to give some CPAP or BiPAP. So child tries to fight, tries to cough, tries to pull the mask. So we generally end up sedating a bit or giving a bit of analgesia to initially cooperate, and gradually when the child cooperates, then we tend to wean it off and make sure child is comfortable. So when there is dysynchrony, the gas can leak out through the edge of the face. If it's not tightly fitting, you can expect leaks, and it may not deliver the amount of pressure that you would want. Lot of air blowing on the nose can actually distend the stomach. They may end up vomiting the stomach contents and cause a bit of aspiration sometimes. That's why we always put an NG tube, keep it open, empty the stomach prior to start of the NIV. And of course, if there are tight fitting with your belts and putting it for a long time without any gap can cause a bit of facial injury. It's very important to take care of the skin of the face in such patients. The interface needs to be kept open for some time. There is a bit of a break needed for the children sometimes. Of course, if you are giving too much pressure, sometimes the lung may be a bit fragile. Especially this, we see sometimes in a difficult bronchiolitic baby struggling to breathe and fighting against the mask. There can be pulmonary air leaks. Sometimes this is a rare complication, but not an uncommon complication. We have seen one or two who end up with air leaks, and of course that can lead to decreased cardiac output later on. Whom can we not try an NIV? So NIV is definitely not indicated for someone who's already declared that this child needs full ventilation. Let's say there is a child in emergency with ARDS, with a pH of 7.1 and a very high CO2, and the oxygenation is on 100% oxygen. He's declared that he needs full ventilation. I think there is no point in trying a bit of CPAP for some time. There is no such. Of course, to try NIV, the most important thing is we need a good conscious child with good spontaneous effort of breathing. Our NIV only supports a spontaneous breathing child and improves a bit of giving a bit of positive pressure support, and improves the oxygenation by improving the inspiration as well as expiration. But so for that, you need a very conscious child who's having good spontaneous breathing. Of course, if you are unable to tightly fit the mask on the face due to some kind of facial injury or a neurosurgical injury, you're worried that it will cause pressure and cause more wound on the face, that again can be a contraindication to use in an IV or a BiPAP or a CPAP. Okay, please feel free to interrupt me in between if something is not understood. I'm okay to answer questions in between. Thanks. Quickly going through the interfaces. So there are two types of mask: vented mask and the non-vented mask. The vented mask is something where there is an exhalation port that is present separately. So we don't have to include the port within the circuit. We need not be used for it. Whereas in the non-vented mask, there is no exhalation port. So you need in the circuit itself, you need a port that can be used for exhalation. I'm sure all of us are aware of those masks. I was told to speak something about humidification and told to give more importance to humidification part, because that's a bit new and there is so much of advance that's happened with respect to humidification. Traditionally we were using usual air and not worrying much about the humidification part. And of course, we have a decade ago, I think we have seen enough number of complications due to dry air, and we never realized those complications were due to the dry air. But now this amazing advancement in science has come in, and humidification has definitely made a difference in outcomes of children by using the NIV. quickly, we all know that our usual body temperature is around 37 degree. When we take in the air, which is cold air outside, when the air, by the time it goes in, it becomes normal temperature. I think all that is done by our air passages. There is this upper airway and the lower airway. The upper airway takes care of filtering the air by various reflexes, various filters that are present along the way. So we know that a certain amount of dust and secretions will all be filtered along the way in the upper airways. But when you use the NIV, or even when you intubate a child, you are actually taking away the defense of the upper airway, and the lower airway straight away is like exposed to all the contamination that you may introduce, and there is a risk because of that. That's where the importance of humidification comes in. Of course, we all know that people sneeze, people cough, people gag because of any dust and foreign bodies that may enter into the system. In the lower airway, the natural reaction is to produce a lot of mucus and try to limit the dust movement or the other foreign body movement. We, of course, are used to seeing lots of mucus secretions getting accumulated when we have used the dry NIV. So most of the heat and moisture is lost to the environment during exhalation. As we know that, let's say during inspiration, when you take in the cold air, the passages, make sure that along the way the air gets a bit warm up, and by the time it reaches inside, there is a temperature, certain amount of temperature that's maintained. I think the optimum temperature that we are looking at is around 32 to 34 degrees. That is needed for the body. So people have done a bit of studies and checked what could be the optimal humidity. How much humidification should I maintain to make sure the secretion don't dry up? On the other hand, it should not be too much to accumulate in the body. So the meaning of optimal humidity is that amount of humidity that is needed to make sure the mucociliary function is maintained. It should, of course, prevent drying of the mucus, because that becomes the main issue for the physiotherapist. We end up doing lots of tapping, lots of nebulizations to clear up the secretions later on. Of course, optimal humidity is something that will help in clearing all the secretions and maintain a patent airway, especially in distal airways where the distal bronchial level airways, and make sure it doesn't collapse. Also, it should the humidification should make sure it's all dissolved well inside, and it should be easy to suction it out and for the child to clear it all. So let's also look at other issues. I'll go quickly to the studies that are important for humidification. There are few studies that I've gone through. People have checked whether the humidity is important, and maintaining a particular amount of temperature in the system is important to improve the outcomes of the. It could be a neonate or an infant or a child. So people have done a few studies. Let's look at one or two here. As we can see in these results, William et al. In 1996, I think this is published in 1996, and the clearance definitely improved as and when the humidification improved from 30 to 44. You could see maximum amount of clearance happened at a higher level of humidity, somewhere around 40s, and definitely there was a improved mucus clearance, and there was minimum damage to the lungs and mucociliary function. Similarly, there are others which have clearly told us. There's one study in 2014, definite improvement in clinical outcomes when we use the heat and moisture exchange HME filters along with tracheostomies. So and there were reduced side effects due to this. Okay. Sorry. Just going back. Oops. Right. Similarly, there is a study based on in children with bronchopulmonary dysplasia. These are common in this in ICU setting. We see lots of these chronic lung patients who come with born very early with premature lungs. We have given the surfactant, but they end up staying for weeks together on CPAP, and occasionally come out and keep going back. Those are the children where even tiny amount of secretions matter, tiny amount of even small things matter in such a fragile baby. So there, I think this good humidification is very important. Good clearance is very important. As we know, the preterm baby has a very fragile chest with a small amount of ability to cough out secretions, and quite a weak, fragile baby. In that, even a minimal amount of secretion accumulating can make a big difference in outcomes. So that is where optimal temperature maintaining is a must. So I'm unable to. Yeah, there you go. We in Sparsh Hospital, actually, we have used for 2 patients recently. We used, there was a cardiac baby who was operated for VST, AST, and PDA. And we ended up using the, Archana was kind enough to offer a humidification circuit, and we ended up using it. I think we saw a definite difference between the usage of the last year system versus this year system. So I think we have decided to continue it in our PICU. We'll continue to use those tubings. Thanks so much for that. Okay. Is there any questions to be answered so far? There's nothing I can see in the chat box here.
Not yet, sir. Not yet. But
okay.
We'll allow the participants. They can post anytime the questions in QA box. And
right.
Presentation will.
Yeah. My talk is almost done. I can pass it on to Dr. Surendra.
Okay, sir. Thank you so much, sir.
Yeah,
Dr. Surendra.
Yes, I'm here.
Can we start your presentation? Can I share your presentation?
Yeah. Kindly share.
Just a second.
Hi, Surendra.
Hi, sir.
Is it visible?
Yes, visible. Yeah. Am I audible?
Yes.
Yeah. Thank you, Ratnakar, for your wonderful introduction. And at the outset, I would like to thank Bishop Ekal for giving me this opportunity. And Dr. Sanjay talk was very short, sweet, and it was very useful. Today, my topic is HHFNC, that is heated humidified high flow nasal cannula. Yeah, this I'm using for last almost 10 years. This I've used extensively, and it is very beneficial and very cost-effective machine. And I've used very personally multiple times. I could able to save many kids who required intubation and decrease. And one of the study in India, which was first done in Kanchikamakoti in 2013, I was part of this study. So we have extensively studied, and even in our Vrindavan area hospital where I'm currently working, we have 6 HHFNC machines. And after COVID, like everybody started using, even in adult also. And during COVID period, HHFNC machine was used extensively. Now everybody is aware of HHFNC. I would like to give what is HHFNC, what are the indications, what is the mechanism, and what are the usefulness. I'm going to talk. Yeah, next slide, please. Yeah, OptiFlow in infants and pediatrics. Coming to the optimization of patient journey, it is the earlier the use, it's the better is the outcome. The duration of the hospital stay is short, and the length of ICU stay is short. And most of the time, I've used this HHFNC machine extensively in case of bronchiolitis, where it prevented intubation rate by 80%. So coming to this, already we spoke about invasive ventilation, nasal CPAP, and there is oxygen therapy, which the disadvantage of oxygen therapy is only 2 liters we can use, and without humidification. Without humidification, it causes a lot of dryness. So today I'm talking about nasal eye flow, where there are a lot of evidence which is showing there are more than 90 papers which is in favor and users of eye flow nasal cannula. Look at the chart where the usage has double, or I would say 10 times it is increased after COVID. In 2000 onwards, it was less, but it started after 2012 extensively, whereas after 2020 onwards, it has 10 times increase in the usage of the HHFNC machine. Yeah, next slide. Yeah, coming to the mechanism of HHFNC, the mechanism I'm going to distribute in 4 parts. One is respiratory support, that is then airway hydration, then how does it give supplemental oxygen, and coming to the patient comfort. In this, first I would like to discuss about respiratory support. In respiratory support, mainly how does this HHFNC help is reduction in the dead space. The dead space is the one we have anatomical dead space and physiological dead space. Anatomical dead space is the one which is airway, which is not useful for oxygenation, mainly in the trachea, bronchioles, and bronchi. Whereas physiological dead space is the dead space where alveoli, which are not blood supply is not there, where there is no oxygenation. So coming to look at the picture, where is a first picture which is suggestive of normal breathing, where there is a mixture of air and oxygen. When you use OptiFlow, even the upper airway is replaced by the air is a combination of oxygen, carbon dioxide, which is replaced purely by 99% of the oxygen. So that is one. So coming to the how does it use pharyngeal pressure continuously. So as Dr. Sanjay said, there is a in a CPAP there will be continuous delivery of the pressure 5. Even there is a little dynamic variation in the pressure, but it's not like CPAP where it gives continuous, but here dynamic pressure continuously during both during inspiration and expiration. Coming to the graph, you just compare without eye flow and with eye flow. With eye flow, the pressure varies from 3 to 6, but definitely average pressure of 5 peak pressure it will give. So that is the advantage, and it prevents the collapse of the alveoli. That is one advantage. It is like CPAP, but whereas in CPAP it gives continuous, whereas in HHFNC there is a variation in the pressure. And compared to unassisted breathing, the eye flow decreases the work of effort, promotes the slow and deep breathing. And how does look at another picture where there is reduction of the dead space. Look at this. There is a dead space volume and alveolar volume without eye flow. With eye flow, look at this. By washing out the carbon dioxide which is in the airway, it is increasing the space, and also sometimes increasing the de-recruited lung or closed alveoli. Also, there can be open up of alveoli, and which helps for the oxygenation. Next slide, please. Yeah. Then next mechanism is accurate oxygen delivery. The more accurate oxygen delivery only by few things. You have low oxygen delivery or high flow and low flow. Low flow where you can't you have Venturi, you have just simple mass or NRM. You really can't deliver how much FiO2 you require. Whereas through HHFNC, you can really give how much FiO2 you require. Look at the low flow oxygen therapy in the first picture, where look at this, like maximum when you 4 to 5 liter per minute, look at the oxygenation. And this one coming to the eye flow, look at the airway, completely the upper airway is filled with the 100% FiO2, completely filled with 100% FiO2. That is the advantage. Then airway hydration, look at the optimal airway hydration. As humidification, as Sanjay sir said, humidification is very important for the mucociliary activity, and the healthy epithelial cells is very important. So good humidification clears maximum clearance of the mucus. Enables the comfort delivery of eye flow. So sir said with optimal humidification, the mucus clearance will be good. Whereas with your regular oxygen flow, there's no humidification, the secretion will not be so good. So one is by humidification, it prevents the dryness of the nasal and there is no necrosis, and prevent desiccation of the airway epithelium, improves the mucus clearance, conserves the energy of growth and development. Coming to the airway hydration, look at the epithelial cells of the trachea, and with 100% immunity, look at this. How is the epithelium? We went with 90% humidity for 15 minutes. And same picture, you compare 100% humidity after 1 hour, the epithelials are so healthy, whereas the epitheliums are so dry after 1 hour if you use regular oxygen. So there will be destruction of the cilia of the epithelium, and there's no easy clearance of the mucus. So that when there's no easy clearance, the work of breathing increases, and the improvement of pneumonia delays down. So patient comfort is very important. With this HHFNC, patient can be like KMC can be done, and patient can carry. And this eye flow, the one advantage, you can move the patient also. With inbuilt battery and with oxygen cylinder, they can move around also, like in a chronic patients. Next slide, please. There, 1 minute. Yeah, with eye flow therapy, what are the benefits? It's like similar efficacy of nasal CPAP, associated with reduced escalation and length of ICU stay, indication for reduced intubation, I've already told, less nasal trauma, no significant difference in the adverse effect, improved bonding with the patient and the parent, comfort and well tolerated, very easy to use, empowers parent, and improved caregiver satisfaction. Sometimes this can be used in case of like cystic fibrosis, even at home also. Look at the optimum humidification, which already Sanjay sir discussed, like 37 degree, and with humidification, micron, virus, bacteria, and all. Relative humidification of 100% is very important to clear the mucus. Yeah, next slide, please. See, OptiFlow in infants and pediatrics. What are the evidence supporting early use? There is uses maybe physiological outcome and clinical outcome. As I discussed already, in a physiological thing, it improves the breathing, decrease the dead space, and decrease the work of breathing. That is the more important. And the clinical outcomes, reduce clinical deterioration, decrease intubation rate, reduce PICU stay, and even that I would say generally we use in India the HHFNC in PICU, but whereas in abroad they use even HHFNC in ward also. What are the clinical rationale for use in early? So as it's like indications are similar to that of CPAP, that is hypoxic respiratory failure, more common, 80 to 90% I use this HHFNC in my setup for bronchiolitis, and mild to moderate pneumonia, mild to moderate ARDS, and most commonly post-cardiac patient, or mild case of ARDS, I would say, and who are like NAV in a pediatric less than 6 years, very difficult. One is patient is not cooperative and mask doesn't fit. So during that time also, most of the time we use HHFNC, and pre and post operative intervention like bronchoscopy. And most of the time in my unit, post extubation, even in NICU and PICU, more than CPAP, I use iFlow nasal cannula, which I use in and out actually. Yeah, next slide. Yeah, OptiFlow in pediatrics. We already discussed how to set up. So you know what is OptiFlow, what are the indication, what are the benefits we know, and how to set up OptiFlow. I think there is a from here from oxygen there is a tube coming to the blender. Through the blender flow coming to the humidification, from humidification tubics to the patient, and then the interface. So once we have set humidification, automatically it will end up. Coming to this flow, how to set up flow? Coming to flow, there are 4 ways to set up. One is flow based. Flow based means you decide how much, like fixed flow, maybe 1 liter per kg, like that. But most of the time, what I practice is start with 2 liter per kg, then titrate according to the effect. Sometimes if patient is like workup breathing is more, you can increase to 2.5 liter per kg, or you can increase to 3 liter per kg. Or if patient has improved over that, you can come down to 1.5 liter. So titrate to the effect is one thing which I come. Or combination of 2 to 3. Yeah, generally I use 2 liter per kg, then titrate to the effect. So once you start, what to look for? Once you start, there should be improvement clinically and monitor wise. What are monitor wise improve? There should be improvement in respiratory rate, improvement in the heart rate, and there should be decrease in the workup breathing, and saturation should improve. So when you say improvement in respiratory rate, improvement in heart rate, then you say your HHFNC is working. If there's no improvement, then revise your diagnosis or think of NIV or ventilation. So most of in my experience, I've seen drastic improvement within 1 to 2 hours of starting high flow. So I already told how to set up the flow. So depending upon weight, you can start. Generally, the general guidelines is 2 liter per kg and titrate to the effect. Yeah, next slide. And FiO2 you set up depending upon the requirement of the patient. Yeah. So these are the connectors of the OptiFlow. This is the interface. Look at this interface where there are very soft and easy to attach. There's no much to explain in this. And the 3rd generation interface are very good and very comfort. Yeah. Next slide. So these are the different generation of the OptiFlow. So there's no much to explain. These are different sizes are available, including for preterm, neonate, and infants and pediatrics. Yeah, next slide. So one more thing, coming to the circuit, one important thing about circuits is there is a reduced formation of the condensation, and even with HHFNC, child can read, write, eat in a chronic cases, and very easy for acceptance, and very easy to set up. Even a newcomer of a sister can use it. And one more thing which I told, continuous power for continuous therapy. That means continuously it can be used during the transport of the patient, transport to the ultrasound, transport to the any imaging, and to mobilize the patient also you can do with inbuilt battery. It's an excellent instrument which I have used in my clinical practice. Yeah, next slide. So there are multiple papers post extubation which is used to decrease the requirement of ventilation and decrease the ICU stay. And also there are many more papers which suggest you that early usage of HHFNC decreases the intubation rate, decreases the hospital stay, that is PICU stay. Yeah, next slide. Yeah, I think that's me. Yeah, thank you everyone. And any questions you can ask me.
Excellent talk, Dr. Surendra. Excellent.
Thank you, sir. Thank you.
Thank you, sir. Thank you for excellent talk. We'll wait for 1 minute, sir. If any questions comes in the chat box, then we'll address them, or else we'll finish the session here.
Can I ask one question? Dr.
Yes,
Surendra,
yes, sir.
this
Yes, sir,
weaning
yes,
of this weaning of OptiFlow is a very interesting topic.
Yeah.
I think so. Once upon a time, let's say 5 years or 10 years back, we used to like when the lungs are getting better and we wanted to wean the patient, we used to let's say he was on 20 liters or something. We used to reduce it by 2 liters every sixth hourly, or 4 liters every sixth hourly, and slowly come out of it over the next 24 hours. That was the usual strategy. Do you think that should still be continued, or nowadays I think there are new
No,
studies.
sir. Actually, there are no guidelines how to wean up. It is like how we wean up from ventilator, how we try spontaneous SBT like that.
Correct.
So nothing like
Correct.
previously, even on ventilator also FiOT, if it is 100, every 2 hours on 10, nothing like that. Every 5-10 minutes,
Correct.
it's about the what is the indication for what we are using, how fast is the patient is improving. Generally, 2 liter per kg we use. I make it like after improvement 1 liter per kg, then I wean it up. But sometimes what I do is, sir, instead of using 1 to 2 liters of regular oxygen, even that low flow only I used it till, because already patient is charged for the circuit. So generally till I wean off from the oxygen, I continue to
use it as a low flow only. Sure.
Yeah, sir.
Sounds good. Sounds good. I think the key factor is when the lung is ready, you can wean off quickly. I think that's the main key point, isn't it?
Sir, we have used, because first time I used this in 2013 in Kanchikam. Extensively we use, even in dengue patients who are in shock, many patients, particularly in bronchiolitis and post-operative cases who required support, but it's an excellent. But now after coming here to Bangalore in 2014, I've used like we have 5 to 6 iFlow.
Yes.
We are using extensively.
It's slowly becoming our favorite device, isn't it?
Yes. Now Venturi and all gone. Yeah,
correct.
We don't use Venturi and all.
We don't like. I mean, there are people who are using it instead of bubble CPAP also, even in the smallest babies. Slowly.
Yes, sir. Even in NICU, we are using. Generally, as not a primary, post extubation I'm using, but not like CPAP where for a RDS.
Correct.
But for all, even in a less neonatal period, also for pneumonia, I'm using iFlow.
Excellent.
Dr. Sanjay, my question to you. Is there any contraindication, not exactly contraindication, but is there any case where the humidification is ideally recommended, especially in pediatric cases?
Where it is recommended?
Where it is not recommended.
Not recommended. No, I think it should be universally used. There is no patient where it should not be recommended, because there is always this risk of drying of secretions and mucus plugging, and that becomes a major issue. Commonly, we use it in the bronchiolitis patient, and there the mucus plugging is the most difficult issue we face. And clearing of mucus plugs is a vital aspect of improving in a bronchiolitic patients. So I don't think we should avoid using humidification in any particular patient.
Okay. Thank you, sir. Thank you. We have one question in chat box. It must be for Dr. Surendra. He want to ask you about the maintenance of the device, basically for airbo, I think so.
See, there is no maintenance, I would say. But whatever I'm using for last 8 years in my setup, I have not come across any issue. And very easy to maintain. There is no difficulty and all. Only one issue which I have faced is for humidification, the bottle which we hang over the machine. When there is a leakage, if it falls on the display, then it's only one machine. Now after that, I'm changing that also, like not to keep that hanging that saline, this one. That is distilled water above this one. That's only. Otherwise, maintenance is easy. Nothing is required. So most of the time, sometimes we use ETO circuit for poor patient. Otherwise, for affordable patient, we use new circuit. For not affordable patient, the circuits are so costly. Otherwise, not much maintenance.
Yeah, no, our respiratory therapists are quite active in detecting things when it needs change of maintenance. So recently, I was using a HFNC, and she on the back of the machine there is this membrane filter which is white in color, and that can become a gray or blackish over a period of time. It's important to check that before you start for every patient. And we changed the membrane recently, so that's why I remember. I think respiratory therapists are very smart in detecting such things.
Thank you, sir. Thank you for sharing your experiences. In addition, we need to change that backside filter after every 3 months. And also, along with the device, we provided the disinfection tubing. So after use of every patient, we need to disinfect the device.
Correct.
So I think so. We can finish the session, sir, here. And thank you once again, Dr. Sanjay and Dr. Surendra, for sharing your intelligent talk with everyone. So thank you once again, and have a nice day.
Thanks, Dr. Ratnakar. Thanks so much for the opportunity.
Thank you, Ratnakar, and thank you, Fisher Paykel. Thank you, Sanjay sir.
Thanks, Surendra.
Bye bye.
Bye, everybody. Thank you.